Om Shri Manjanathaya Namaha. Om Shri Dhanvantare Namaha. Good morning, everyone, and welcome to today's session on neoplasm. Now, I would like to call upon Dr. Murali Sharma sir, Professor Emeritus, Department of Cell Tantra, SDMK Udupi, to take over the session. Welcome to you, sir.
Next is about the renal cell carcinoma, which earlier was being named as nephroblastoma. The present day's nomenclature is renal cell carcinoma. And this occurs in the adults. Now, in the renal malignancies, there are mainly two categories. One, childhood onset malignancies and the adult onset malignancy. Among the adult onset malignancies, renal cell carcinoma is the most important one. And it accounts for approximately 3% of the adult malignancies and 90 to 95% of the neoplasms arising from the kidney. So maximum type of the malignancies occurring in the kidney are renal cell carcinomas. And as for the global issue, it accounts for 2% of all cancers worldwide, with an estimated 431,000 new cases diagnosed in 2020. That's the latest of the data. And geographically, incidence is significantly higher in developed countries like USA, particularly North America, Western Europe, Australia, and New Zealand. Renal cell carcinoma is the 13th most common cause of cancer worldwide. Now, as far as the data in India, the available data from Indian sources is the estimated incidence of renal cell carcinoma among males is about 2 per 1 lakh population, and among the females it's about 1 per 1 lakh population. Compared to the Western countries, the incidence is lower. And renal cell carcinoma constitutes about 3% of all adult cancers and 85% of all kidney tumors. The Globocon 2020 report indicates that kidney cancer is the 14th and 15th leading cause of new cases and deaths, respectively. That's in India. And as far as the variations in the presentation, in India, renal cell carcinoma is more common in elderly, with the median age of presentation from 50 to 60 years. One study showed that renal cell carcinoma was more frequent in younger people in India, with 1/3 of patients being under 50 years of age. So there is a bit of data overlapping. Average on an average, it's the late middle age, that's beyond 50, is the most common condition. Male to female ratio of renal carcinoma is around 3.6 to 1. So in the male it's much higher than that of the females. Among the data available in India, again, the right kidney was involved in 53.3% cases and left kidney in 46.7% cases. As for the available data, a review article which was published recently, it's 2021, it was published, and as per that, the right kidney has a higher chance of developing the cancer, but of course the reasons are not known. And the upper pole of the kidney was affected in 35% cases and lower pole in 45% cases. That's also another of the issue. And in fact, majority of the cases whom we see would be in the lower pole than really the upper pole, because upper pole would be connected to the adrenals, and it affects the adrenal glands also. 80% of the tumors are located at the poles of the kidney, so that's also true. Whereas the middle portion is comparatively less common, only the upper or the lower pole is more commonly involved. A significant number of patients were asymptomatic, and renal cancer was diagnosed incidentally. Now, as far as the histological classification of renal cell carcinoma is concerned, again this also is a bit more detailed issue. Based upon the histological identification, it's classified as a clear cell carcinoma, which is also known as a hypernephroma earlier. It constitutes 70 to 80% of the cases, and it arises from the proximal convoluted tubule, and in the microscopic appearance it contains large uniform cells with clear cytoplasm, and hence the name of a clear cell carcinoma comes in. And highly vascular, it's having more blood flow, and it also has a subtype called as clear cell multilocular renal carcinoma. Papillary renal carcinoma constitutes around 13 to 20% of the patients. So majority of the patients are clear cell carcinomas, which are highly vascular. And this papillary carcinoma occurs from the distal cannulated tubule and may have multiple focus, and is associated with the chronic hemodialysis patients who are on hemodialysis patients. They have high chance of developing this carcinoma. Then clear cell papillary renal cell carcinoma is one more variety, or chromophobe renal carcinoma constitutes about 5% of the patients, and collecting that renal cell carcinoma is less than 1% of cases. And medullary carcinoma is a rare. Sarcomatoid cancer also is a very rare condition. As far as the etiological factors are concerned, as the known etiological factors and the published results, obesity is a risk factor, particularly in women. Increasing body weight has a linear relationship with increasing risk as such. Hypertension also is a possible risk factor. Occupational exposure to certain chemicals such as trichloroethylene has been linked to increased risk of renal cell carcinoma, and the risk of renal cell carcinoma increases with the duration of exposure to benzene, benzidine, cadmium, etc., herbicides, and vinyl chloride. Now, another of the articles says chronic hepatitis C infection and a meta-analysis of pooled data shows that kidney stones in males are associated with the higher incidence of kidney cancer. Now, this also is something controversial, like hepatitis C infection and renal calculi. Whether they can really result in renal cell carcinoma or not is a debated issue, but some of the data suggests that there is a higher possibility. Then the other is the genetic factors. Genetic factors, now they have identified around 11 genes which are responsible for the renal carcinoma, which occurs in the families of patients with renal cancer syndromes, and it's also now they have named now this as a predisposition syndrome or cancer syndrome as such. Now, the clinical presentation of renal carcinoma is one of the most troublesome issues. It remains clinically occult. Doesn't present with a typical clinical presentation in majority of the patient, and the usual classical clinical symptoms which we say is the flank pain, hematuria, and a mass. Mass, of course, is very rarely palpable in case of renal cell carcinoma, because compared to the childhood cases like Wilms tumor, the size of the tumor is very small, and hence rarely it is palpable, and palpable in only 10% of the patients. In other conditions, it may not be palpable. Of course, a palpable mass also, according to some data, may be seen in 25% of the patients. Hematuria or flank pain could be seen in 40% of the patients, and majority of the patients, 25 to 30% of the patients, are asymptomatic, and they are diagnosed with the carcinoma when some other radiological study was done for some other reason, and that's one of the important issue. The other signs which may be seen in patients of renal cell carcinoma could be weight loss, fever, hypertension, hypercalcemia manifestations like calcifications or even thrombosis, etc. Night sweats, malaise, varicocele in 2% of the males, usually left-sided due to obstruction of the testicular vein. A varicocele occurring in a male and in particularly left side has to be carefully evaluated, because it always suggests of a compression of the renal vein, and hence every patient with a varicose vein on the left side, you have to evaluate the patient by ultrasonography or other investigations, relevant investigations with the detailed history. Though the history may be negative, many times it could be seen like. That's about the various clinical symptoms. Another group of the clinical symptoms which can lead to the suspicion could be what we call as the paraneoplastic syndromes. Paraneoplastic syndromes are a group of symptoms which could occur in any patient who has a malignancy, and they may be a clinical consequence of the reaction of the body to the malignant cells, as well as the biochemical effects of the malignant cells. The exact mechanisms are not known. Of course, maybe at the end we will discuss about paraneoplastic syndromes as a separate topic later on in due course of time, maybe if possible. Now, anyway, in case of the renal carcinoma, the common paraneoplastic syndromes which could be seen are the increased number of RBCs, hypercalcemia, the calcium level could be increased. Hepatic dysfunctions, liver metastasis may be the symptoms, or polyneuropathy, and these together is called as a stopper syndrome. The erythrocytosis, hypercalcemia, and hepatic dysfunction. And the other symptoms which could be occurring could be polyneuropathy, amyloidosis, where there could be deposition of the amyloid substances, anemia, fever, cachexia, weight loss, dermatomyositis. Now, this is important. Dermatomyositis is another of the condition which often can present as a common paraneoplastic syndrome, and years are being raised. Hypertension also is associated with the renal cell carcinoma, but none of these are very specific of the renal carcinoma, and most of the times they are clinically misleading, because whenever you find these symptoms, usually we suspect about, or the clinical approach would be directly to tackle those clinical symptoms as such, and hence often the diagnosis is missed. Approximately 30% of the patients with the renal carcinoma present with metastasis. They are not diagnosed at the early stage. Only when they have the metastasis, they may be diagnosed, and the symptoms produced due to metastasis could be the presentation in such cases. And the metastasis could occur quite frequently in the lungs. 70% of the patients of renal cell carcinoma would present the secondaries in the lungs. Now, this is again very classical. Usually, metastasis in the lungs is more common in sarcomas than in the carcinomas. Carcinomas, they tend to produce the metastasis in the lymph nodes and then to the other organs. Renal cell carcinoma has a high chance of developing metastasis in the lungs, and the radiological appearance also is classical. I will show you the image of that also later on. That typical cannonball appearance is seen in case of the metastasis in the lungs. Then there could be metastasis into the soft tissues of the body, like the adipose tissue, metastasis in the bone, kidney cancer producing the metastasis in the bone also is common, and it's a classically osteoclastic type, osteoclastic, where the bone is necrosed. Again, I will show you the examples, the image also later on. There could be metastasis in the liver in 18%, skin sites 8%, central nervous system in 8%. One of the important issue which you should not forget is in a male patient presenting with a varicocele, and along with the finding some signs of paraneoplastic syndrome like hypertension, supraclavicular lymph node enlargement, or abdominal mass, they should always be explored for the possibility of the renal malignancy. Determining whether a space occupying renal mass is benign or malignant is quite difficult. So, none of the investigations would confirm whether a abnormal mass seen in the kidney is benign or malignant. And CT is the imaging procedure of diagnosis chance, because ultrasonography may show the mass, but it may not give you an idea like whether it is really malignancy or benign. Ultrasonography examination can be useful in evaluating cystic renal lesions if CT imaging is inconclusive. Earlier, in the older days, IVP or excretory urography were considered as a standard investigation tool, but now that has become obsolete because chances of missing the diagnosis are very high. The different types of imaging modalities now these days, because the clinical diagnosis is difficult, lots of techniques of these imaging techniques are used for confirming the diagnosis of renal cell carcinoma in advanced centers. Of course, we may not be able to do all these investigations, or many of them may be not accessible in our setup, but the standard protocol could be CT of the abdomen with pelvic CT or MRI, which we can do, ultrasonography, chest CT scan, excretory urography, renal arteriography, venography, bone scan if bone metastases are seen, brain CT or MRI. A gross specimen of renal cell carcinoma during surgery would be seen as focal lesions which are producing some irregular masses in any of the poles, either the lower pole or the upper pole. That would be the typical presentation of a renal carcinoma seen under the gross image, like during exploration. Ultrasonography may show you a mass, typical, but Whether it's malignant or benign is not possible. A irregular shape of the kidney area, and if there is a penetration, the lesion has crossed beyond the Garrot's fascia, that also can be made out with the ultrasonography. So that's one of the tools which could be useful and it is easily accessible. Contrast enhanced CT is another standard tool which is also a benchmark now, where the consistency of the mass, that dense mass with the central necrosis, can be seen with the contrast enhanced CT, which is almost considered as a standard protocol of the investigation. MRI gives you a clear cut picture of the mass which is extending beyond the area of the renal fascia and reaching up to the soft tissues of the pelvic area. That also can be made out with that. Of course, the PET scan, as usual, is considered very accurate, and it also helps in making the diagnosis of secondaries, lymph node involvement or other secondaries can be made out. In this case, it's in the upper pole that you see that hypermetabolic lesion suggestive of the renal carcinoma. Grading of renal cell carcinoma is as usual in the TNM pattern. T0 is no evidence of the tumor, T1 is less than 7 cm, and T2 is more than 7 cm, and but confined to the kidney. T3 is when extends into the major veins or perinephric tissues, but not into the opposite side or renal, the suprarenal gland. And T4 is a tumor inverse beyond the Gerota fascia and contiguous extension. Of course, there could be subclassification as 1A, 1B, or 2A, 2B, or 3A, or 3B, 3C, depending upon the further extension. Now, regional lymph nodes, like no regional lymph nodes involved, M0. When lymph nodes are involved, of course, metastasis into the lymph nodes, and M0, M1 as usual. Then the another classification, American Joint Committee classification, has made it as a stage 1, stage 2, stage 3. Stage 1 is 7 cm or smaller and confined to the kidney. Stage 2 is larger than 7 cm but still confined to the kidney. Stage 3 is the tumors extend into the renal vein or vena cava and involve the adrenal gland or perinephric fat. And stage 4 is tumor has gone beyond the Gerota fascia and spread to the local or distant nodes having distant metastasis. Of course, the metastasis, of course, this is a bit of repetition of the issue. Metastasis occurs more frequently in the lungs, the common side, and high percentage of patients. Bone metastases also are frequent, involving the spine, ribs, and pelvis. Lymph nodes, regional lymph nodes of the kidney are commonly involved. Liver metastasis also relatively common. Brain metastasis can occur, although they are less common. The typical presentation of a secondaries from the kidney into the lungs, that would be presenting with the typical cannonball appearance. That is once you see this kind of roundish lesions, that almost confirmatory of renal cell carcinoma. And in the bones, it's particularly in the long bones or the spines, a osteoclastic lesion with no reactionary changes, a typical area of complete hollowness, that lesser density, and no other reactive changes around. Periosteum being involved is the typical sign of a osteoclastic secondary in the bones, and a good number of patients of renal cell carcinoma are diagnosed with these radiological features in our setup. As far as the treatment is concerned, surgical resection is the only curative treatment for the renal cell carcinoma, and it's also used as a palliation in metastatic disease. In a patient who has a metastatic, removal of the primary may help in prolonging the life of the patient and reducing the complications. Radiofrequency ablation or by a interventional radiologist can be considered as an alternative for small lesions. Now these have become now more popular now. Ablution with the radiofrequency, which is a more technological issue, or targeted therapy with the minimal drugs also are considered as a standard in the metastatic disease. And one more of the new area which is coming up is because it's a immunogenic tumor, the spontaneous regressions have occurred in good number of patients, and immune modulators are used successfully, and these days lots of research articles are coming up with the information about the immunomodulatory drugs used in case of renal cell carcinoma and having some better outcome. And among those tried now are interferon or interleukin and a programmed cell-based protein receptor blocker, which is nivolumab, which also is becoming, or rather you may find a large number of reports of that sort. BCG, as in case of bladder carcinoma, BCG vaccination also is now becoming popular. Autologous vaccines now are coming up. Lymphokine activated killer cells plus the IL-2, that's interleukin. This combination also is being tried. And tumor infiltrating lymphocytes, formation of modification of the lymphocyte genes into tumor infiltration is one more area, and non-myeloablative allogenic peripheral, but all of these are still in the initial stages of the research. They have not become popular, but lots of researchers are going on this area. Maybe in due course of time you may have some of these becoming a standard protocol, and one of the malignant lesions which can be controlled without chemotherapy and only with the immunomodulator drugs could be possible. Prognosis of renal cell carcinoma has changed now, and in general the prognosis has improved now compared to the earlier issue, and 5-year relative survival rate is around 93% in the patients who have been diagnosed in stage 1, that's the dark line, whereas the patients who are diagnosed in stage 4, the survival period becomes lesser. So that's the issue. Early diagnosis can help in the prognosis as such. That's about the renal cell carcinoma or hypernephrom. The next variety of the tumor related to the kidney is the Wilms tumor or nephroblastoma, which is a typical pediatric tumor seen in children. And the Wilms tumor historically is a cancer which affects the kidneys, and named after German surgeon Max Wilms, who was described in 1899, and is now highly treatable condition with survival rates of exceeding 90% now. The current survival period is around 90% in all patients of pediatric conditions, whereas earlier the prognosis was poor. Now, as far as the epidemiology is concerned, Wilms tumor appears to be relatively more common in Africa and least common in East Asia, and incidence in Europe is similar to that reported in North America. Low income countries have a higher median incidence of Wilms tumor, 9.8 standardized per million population, 9.8, and high income patients comparatively, high income countries 8.6. Comparatively there is a difference as such. Middle income countries 6.1 is the other issue. Comparatively in India, compared to the global incidence, the incidence is lesser. 90% of the Wilms tumors are diagnosed before 6 years of age, and the median age of diagnosis is 3.5 years. As far as the global incidence is concerned, of course India also is included in the same, but the incidence of in India is comparatively 4.4 per million population, whereas in the high income countries like Bahrain, Israel, etc., the incidence is higher. The maximum is in Bahrain. So that's the typical presentation of the lesions. It's, as far as the pathological etiological factors are concerned, it's known to be produced due to gene alteration, which is responsible for the development of the genitourinary organs, and commonly the patients of Wilms tumor would have some other abnormality of the development of the genital organs, like cryptorchidism, where the testicles may not have descended, or the structural abnormalities in the kidney, like collecting double pelvis or horseshoe kidney, or hypospadias, spinal organ having the urethral opening at a base as such. The most common manifestation of Wilms tumor is a asymptomatic abdominal mass. A child presenting with a huge abdominal mass is seen in majority of the patients, and 80% of the patients would have a mass, and the mass is quite big and easily palpable, and it is known to displace the organs towards the opposite side, the intestinal condition organs, and hence a plain X-ray also could be useful in making the diagnosis when you have a retroperitoneal mass suggesting showing the displacement of the intestinal loops, and hence a ground glass like appearance in one segment of the abdomen would be the classical radiological sign of the Wilms tumor. And abdominal pain or hematuria may occur in 25% of the patients. Repeated UTI or varicocele are less common in case of Wilms tumor. Hypertension, hematuria and fever is seen in 5 to 30% of the patients. Any abdominal mass should be carefully examined, particularly if you have suspected Wilms tumor. Palpation should be very careful. The vigorous palpation can lead to rupture of a tumor into the peritoneal cavity, and acute emergency could be produced. So whenever, if at all you get a patient of Wilms tumor, you have to be very delicate in palpating the mass. The mass could be quite huge. That's important. Appearance under this gross appearance will be shown as a mass which is extending in the kidney, and a huge mass size is quite huge, and a plain X-ray typical that ground glass like appearance with the displacement of the gas shadows to the opposite side is seen. USG is very classical, where you can make out that mass, and rarely it involves the perinephric space. The perinephric space is free, and the capsule, the keratospacia and the renal capsule, they are not really involved in majority of the patients, and that can be easily made out in ultrasonography. CT or MRI also can give you the clear-cut idea about the consistency and presence of necrotic area within, that also can be made out. MRI, it shows the pressure effect on the nerve nearby organs, and secondaries in the lungs also can be made out in the MRI, but secondaries in the lungs are seen as a solid masses, not the these typical cannonball appearance in case of Wilms tumor. Staging of Wilms tumor almost on the same lines. Stage 1 is tumor is limited to the kidney and is can be completely resected, and or the tumor may be protruding into the pelvic system and ureter, or the vessels of the renal tissue are not involved. Intrarenal vessels involvement may be present. Stage 2 is when the tumor is extending beyond the kidney to penetrate through the renal capsule into the peripheral fat, but is completely resectable. And stage 3 is incomplete excision, that a complete excision is not possible, that's considered as stage 3. Stage 4 is when there is a hematogenous metastasis into the liver, lungs and bones, and stage 5 is bilateral renal tumor set diagnosis. The stage and histological presentation, stage or staging on a histological presentation is histologically they are classified into a favorable histology with the loss of heterogeneity, or favorable histology with the loss of heterogeneity, and stage 1 is when there is no loss of heterogeneity, and that is cell patterns are not affected. Stage 2 is when there is a loss of heterogeneity. Stage 3 is a favorable histology without loss of histology at loss of heterogeneity in the genes as such. And stage 3 and stage 4 favorable histology with the loss of this heterogeneity. And the protocol of the treatment would be, in all cases, nephrectomy is the option of the treatment. Then chemotherapy in stage 1, it's vincristine and dactyomycin which is often preferred, and stage 2 you'll prefer vincristine with the dactyomycin, doxorubicin, 3 drug regime. Stage 4 multi-drug regimes are done, and radiation therapy is required in stage 3 and stage 4, whereas stage 1, 2 radiation is not required. And survival rates in patients with the favorable histology of Wilms tumor is a relapse-free survival period is around 92%, and overall survival period is 98% in stage 1, whereas in stage 4 it reaches to 80 to 90% as per the data. So Wilms tumor now is a completely treatable and the results are excellent. And as many as one third of the patients with Wilms tumor present with hypertension. So even if they are cured of the Wilms tumor, the patients may have a blood pressure being raised for a longer period. A prolonged antihypertensive therapy may be required, and they may have a high risk of developing complications of hypertension because the kidney mass is reduced after nephrectomy. That's about the important issues of this Wilms tumor. With this, we will conclude the chapter on the urogenital malignancies as such. Right. Next, we will take up malignancies of nervous endocrine system, endocrine malignancy in the next session. Right. Okay.
Thank you, sir.